Welcome to the Advanced Methods webinars sponsored by the Agency for Healthcare Research and Quality. Your moderator for today's program is Cindy Brock, Senior Health Policy Researcher at AHRQ. The audio for today's webinar is available by telephone or audiocast. Audiocast quality is subject to equipment, bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option and PIN number provided in your confirmation email. Operator assistance is available to those on the telephone by pressing £0. You may send your questions or comments at any time using the chat window located on the lower left of the presentation window. A question and answer session will follow the presentation. I will now turn the call over to your moderator. Cindy, please begin.
Thanks very much, and thanks everyone for joining us. This is the second in a series of 5 webinars sponsored by AHRQ's Delivery System Research Initiative. That initiative is funded under the American Recovery and Reinvestment Act of 2009, and we do this in partnership with AHRQ's Primary Care Program. Our Delivery System Initiative is supporting research and demonstrations on large scales in healthcare delivery, a very pressing topic in light of our current health system reform. The webinars are intended to help our grantees and other researchers use the most advanced methods available to plan, conduct, and report research on delivery system improvement. So to begin with, we're going to have Brianna Jackson, who's a member of our contractor team here, take us through some polling questions because we'd like to find out a little bit more about you, our audience. Brianna?
So the first question we'd like you to answer today is, how familiar are you with statistical process control? You should be seeing the question on your screen now. Please select the answer which most closely describes you. If you are familiar, you've used it in research and or taught others how to use it. If you are familiar, you've read several papers and or attended presentations, training sessions on its uses, including applications to health services research. If you're somewhat familiar, you have just read or heard 1 or 2 papers or presentations that used it. If you're not familiar, please select that option. We're still receiving a few responses, so I'll give you a couple more seconds. Okay, I'm going to close the poll now, and it looks like the majority of us on the line are somewhat familiar. Our next question should be showing on your screen now. It reads, what is your general level of experience in health services research? Please select the answer which most closely describes you. Still receiving some answers here. Okay, I'm going to give it about 20 more seconds here. And it looks like we're ready to close the poll, so I'm going to stop it now. And the majority of us are either intermediate or at a beginning level in their experience in health services research. So now that we know a little bit more about our audience, Cindy will introduce our speakers.
Thanks very much, Brianna. And thanks for everybody for completing our poll, because, we see that only a relatively small proportion of you are quite familiar with our topic today, and so that can help our speakers focus. Our first speaker is going to be Jill Marsteller, PhD. Jill has been involved in health services research for over 20 years, and she's currently an associate professor of health policy and management at Johns Hopkins Bloomberg School of Public Health. She specializes in organizational theory and behavior as applied to healthcare, specifically in estimating the influence of organizational variables on quality improvement activities. and with a focus on the determinants of successful implementation, dissemination, and sustainability of knowledge. She currently leads the evaluation of the Maryland Multi-Payer Patient-Centered Medical Home Program and works in other primary care sites to reduce disparities in blood pressure control. She also conducts research in the hospital setting, including an AHRQ-funded project to reduce infections and improve teamwork and communication in and across cardiac operating rooms, ICUs, and floor units. Jill's presentation today will draw on her paper with Mimi Huizinger and Lisa Cooper on statistical process control. And this is a paper that has been posted on AHRQ's PCMH website in the PCMH research as a PCH research methods brief. And at the end of our webinar today, we will have the URL where this and other papers have been posted. We are also privileged to have a second speaker with us today, Dr. Stephen Alder, PhD. Steve serves as the Chief of the Division of Public Health in the University of Utah Department of Family and Preventive Medicine. He's an associate professor there and holds adjunct appointments at the University of Utah in internal medicine, obstetrics and gynecology, health promotion, and education. Steve started with the Department of Family and Preventive Medicine in 1995 as a founding member of the Health Research Center. His primary academic focus is in global health with a focus on health disparities. He has several active projects among American Indian communities and in the Intermountain West, and as part of community engagement core of the Center for Clinical Translational Sciences. Steve's a member of the Salt Lake County Board of Health, and he's currently working on an AHRQ-funded demonstration grant called Primary Care Practice Design, Successful Strategies. His presentation today is based on work conducted with research under that grant. So now I'm going to turn the call over to Jill, and I just want to remind everyone that please type in your questions as they occur to you in the chat box. We will be having a Q&A session after the presenters. Go ahead, Jill.
Great. Well, thank you so much for having me, and welcome everybody. Delighted to talk to you today about statistical process control, and specifically we wrote our about how you could use it in evaluating patient-centered medical home models, but it has much broader than that in any kind of quality improvement, and it's being used in lots of different healthcare settings now. So if we could go to the next slide. Just to give you a little bit of background on statistical process control, it was developed in the 1920s by Walter Shewhart, and it was primarily for the purpose of looking at their production of telephone components and the quality of those telephone components. So based on the theory of variation, he was looking for variation in the quality of the components, and specifically he wanted to find things that were kind of accidental problems or accidents in the process that were not efficient, and trying to distinguish those from variation in the product that was just normal and expected as part of the process. It's gaining popularity in healthcare, and the Joint Commission now is using statistical process control in some of its hospital performance analyses. So the key tool that we're going to talk about today is the control chart, and there are other tools as well as part of statistical process control, but this is the one that you will most commonly hear about. And it essentially combines time series data analysis with the graphical presentation of data so that it makes it hopefully much more understandable to a broader array of people. If we could move the next slide. So this slide is indicating to you the use of control charts and gives you a couple of examples of what a control chart looks like. The top one is illustrating what we would call common cause variation, meaning cause variation that is normal or that is to be expected as just a natural part of the process, natural variation, or random variation. And then special cause variation are changes in the pattern of data that you would assign to a specific cause. So it's because you intervened to change things, or you did something on purpose to change your process, or there was some kind of unexpected shock to the system that during your monitoring you become aware of, perhaps because of some kind of unusual variation. So sometimes the cause is good, sometimes the cause is not particularly good. Can we advance to the next slide? So here's a graphic that is intended to kind of point out to you what are some of the features of a control chart. This example is of 30-day all-cause readmission rate, and I believe the numbers are made up, but to show you essentially what the components of the chart are, you can see that the red lines there indicate the upper and lower control limits, and those are typically set at about 3 standard deviations above and below the mean of the process. And that varies a little bit depending on the kind of chart that you're using, but in general it tends to be 3 standard deviations above and below a mean. So you notice that the points in time are arrayed across the chart, and as we move across 4 years of data, shown here on a monthly basis, there is a measurement for 30-day all-cause readmission rate, and then there is a blue line in the middle which represents the mean across that time period. The yellow line that's added to the graph is intended to show a benchmark, perhaps the place you were trying to get to. In this case, no more than 15% readmissions for all cause, let's say. So this essentially shows you what the main pieces of the chart are. So it allows you to look and see what's happening to this specific process or to this specific outcome as time moves along, shows you where the mean is, and then uses those control limits to show you what is normal and what isn't normal variation. So moving to the next slide. The kind of control chart that you use is essentially based on what your data needs are, what specific type of outcome variable it is that you are trying to chart. So, for example, if you were going to use a proportion, which is quite common, it's very normal that we're using a proportion or a percentage, then we use a p-chart. It's just important for you at this stage to know that there are different kinds of charts, so that depending on the nature of the variable you're trying to chart, you need to select the right type of chart. And this slide gives you an example of how you can make the decision as to what is the appropriate chart to use. There are other sources as well, including a good book by Raymond Carey that you can use to help you figure out what is the appropriate chart. But this is just for your understanding so that you are not under the impression that one chart fits all different kinds of data outcomes. Next slide. So what are the reasons for using a control chart? What is important to remember is that there is variation in data that is just noise, right? There are sometimes outcome measures or process measures that bounce around, and they seem to bounce around quite a bit. Some of that noise is natural and is part of the process. It's sort of a normal statistical phenomenon. That can make it hard, though, sometimes to tell what is random noise as compared to what is really a change. And when you're trying to bring about a change in a system, you could see the number dip dramatically, for example, and maybe you think, wow, we really did a great job in reducing infections. And then it jogs back up in the next time period. And so it's hard to know whether that was a meaningful change or whether that was really just kind of a normal bouncing around. And because of that, we think it's helpful to have a control chart to help guide your understanding of whether something is really a meaningful change or not a meaningful change. In addition, it creates a visualization of what's going on with your data. And this can be very handy depending on the different kinds of stakeholders that you're trying to present information to. There are many people who understand statistics extremely well. There are also many people who are not familiar with statistics and with statistical tests. Many of you may resonate with being in a room talking to a group and describing a change and then telling the group that no, it's not actually statistically significant, or yes, it is statistically significant. And then the reaction is kind of, well, I can't really tell, what that means. It doesn't look any different to me. Or it sure looks different to me. I'm going to go change my whole process based on this, when it's not, in fact, reaching statistical significance. So it's important to be able to map out and graphically display information so that it becomes accessible to a larger range of people. And so when people can look at a chart and see many measurements over time and see, a dramatic decline in a line, for example, that can really help them understand the difference potentially between change that is meaningful and change that isn't, with some guidance about, what the confidence limits indicate. And it can also perhaps provide you with some early information about what's going on with a specific process or what changes you're seeing in an outcome over time. And so that early prognostication can be very helpful, especially if you owe a report to a funder, for example, but you don't have enough data for all of the evaluation components that you're planning. This can be a way for you to give them a real sense of how things are going now. Further, it allows you to judge kind of the timing and the degree of information impact that is going on based on this nice chart. So in the blue box there, you can see a question: did the intervention really decrease the use of CT scans? And so the first graphic sort of indicates that there it is describing a difference in two means. But when you look at the overtime data, you can see that it looks like the process had adjusted itself to a lower level before the line that indicates when they started the project. And so in this case, in your pre-post analysis, you might have thought, oh, well, yes, you might have concluded, oh, our intervention was effective. But in fact, the overtime data sort of suggests that something was going on before you even did your intervention to reduce that overall rate. Can we go to the next slide? So the application to healthcare are many, but in particular, we know that reducing variation in the kind of care that's delivered is one of the core tenets of highly reliable care. So if we are trying to provide everyone with consistent quality, we want to try to provide standardized quality, a certain level of good care that is replicable across patients. And so this kind of monitoring of the variation going on can be very helpful to see how tight the variation is, how large are the changes in the kinds of care that you're providing. These are very typically used for quality improvement projects within a specific practice or within a hospital or a unit of a hospital. Practice management issues can also be examined using SPC, such as the number of unpaid accounts and so on could be monitored in this way. A quick quote from Benian and his colleagues in 2003 was essentially arguing that statistical process control is a branch of statistics that combines rigorous time series analysis methods with graphical presentation of data. And this often yields insight into the data that can be accessed more quickly in a way that's more understandable to lay decision makers. So they're reinforcing essentially the point that I was making on an earlier slide. Can we have the next slide? So to use a control chart to evaluate an intervention, you would first establish what the common cause variation is in a stable period, meaning what is our normal variation that we're typically observing. So you would observe the process or outcome variable over time in the absence of the intervention. We normally like to see about 25 data points over time. That can be weekly data, for example, if you have that. Then you would monitor the data for evidence of special cause variation after you make the intervention and try to see whether your intervention, which you mark with probably a vertical line, has made a change in the pattern of the data that you observe thereafter. Next slide. In order to create a statistical process control chart, you would first identify what the process is or outcome is that is of interest. So perhaps you're monitoring HbA1c levels in your diabetic population. That would be an outcome measure. A process measure might be the number of patients that you have a recorded A1c value for. How is your documentation? Okay. Then you would identify measurable attributes of your diabetic care, if that's what you're interested in, and figure out, well, okay, what variables are we going to watch for, use as our monitoring variables. You would select the appropriate control chart that's based on the specific variable that you've chosen, and then use an SPC software to generate the chart type and compute the mean value over the time period of interest. Characterize natural variation using that upper and lower control limit. And you want to use a software because sometimes the calculation of the control limits is not strictly the 3 standard deviations, so you want to use the program that already knows how to generate your control limits for you so that you know that you're using appropriate control limits. Then you would track the variable to observe patterns over time and determine whether the changes in the variable over time meet the criteria indicating a special cause or not. Next slide. So these are the criteria that are used pretty commonly with respect to determining what a special cause variation is. Now remember, the special cause could be good or it could be bad. It could be that, for example, your care managers are making contacts with patients and suddenly you see in one or a slightly longer than 1 month period, you see your contacts go really close to 0. And so that then gives you heads up that there's something going wrong with your process. And cycling back to your care managers, you find out that there were a couple of different problems with the EMR system, and there were difficulties with the cell phone service or something along those lines. That then gives you an idea about what to go in and try to fix if you're using it in more of a monitoring kind of way. If you're using it in an intervention way, then you're looking to see whether the purposeful thing that you did actually changed the pattern of data after the intervention. And you would do that by looking for, you would establish whether that's a special cause variation by looking for one value outside of the control limits can sometimes be a sign of a specific special cause. 2 of 3 consecutive values above or below the mean and greater than 2 standard deviations away from the mean, or greater than or equal to 8 values that are consistently above the mean or below, or greater than 6 values that are in a row, meaning consecutive, that are steadily increasing or decreasing. That can also show a change in the pattern. 4 out of 5 successive points that are more than 1 standard deviation from the mean on the same side of the center line. And then finally, obvious cyclical behavior. So let me just comment that there are different sets of special cause variation criteria that are used. These ones, together from Benian, we hear should let you know that the chance that the changes seen are due to circumstances beyond regular variation is 99.7% if you were to see any of these patterns applying in your data. So on this next slide, you see that we are identifying significance in the SPC chart and offering you some examples. So on this particular slide, you can see an example number 1 point outside of the upper or lower limit. That's what that looks like. For number 2, you can see a row of 6 successive points that are increasing or decreasing in a trend. Number 3 indicates what 4 out of 5 successive points that were more than 1 standard deviation from the mean on the same side of the center line looks like. And then number 4, 2 of 3 successive points that are more than 2 standard deviations from the mean on the same side of the center line. That's just to give you an example of what these different patterns would look like, and you would use these criteria to establish where those patterns are, and then you would either show these relative to an intervention that you did. If it's across time, then you would have a vertical line indicating your intervention and when that happened, or you would go looking for explanations for these special cause variations in a process that you thought was stable. Next slide. So some of the uses of control charts are to monitor process measures, as I've indicated, identifying early signs of correlation that may exist between processes and outcomes. If you've charted both your process and outcome on the same graphic, then you can see where those things are moving together. You can use it to identify differences across groups, again by superimposing the graphics for each group on top of one another and comparing the graphics visually. It's always important, if you think that there is a difference, to test that statistically and make sure that it's a real difference, because sometimes things appear to be differences and in fact are not. And then aid self-management interventions as another use of the control chart. People can use them to monitor their own or to monitor changes in specific patients. In addition to that, you can determine the time from implementation to effect using these charts. Next slide. So this one just gives you a quick view of control chart appointment access satisfaction. And so this is one from an article. Again, I think this was from the Benian article, and it shows you where they tested multiple changes, and you can see the change in satisfaction, and it readjusts itself to a higher level. The next slide is another example showing you control chart of infectious waste poundage. And so here they've shown you what the baseline looked like. They generated one set of information for the baseline, and then after the changes they generated another series of data points, and you can see that there's a marked change and the entire process has reset to a lower level. Next slide. So just to wrap up with our limitations, it's important to remember that this requires frequent measurement, and so it may not be always useful to you if you're not able to get frequent measurements. In addition, there will be some degree of autocorrelation, which means that each data point will be somewhat correlated with the data point that comes before it and the data point that comes after it. And that's because they're all measuring the same process, so there's a good deal of commonality in those measurements. Another way to think of that is it's repeated measurements on the same subject, and therefore there will be a lot of correlation over time. So you need to be aware of that. Typically it's not enough to worry about. Depends on how close together your measurements are. Next slide. The last in the area of limitations is just for me to mention that, again, this isn't going to work. For example, if seasonal variability is known to be a problem, you can be aware of it in looking at your charts if you know it's there. However, if you are don't know of that, then it might impair the use of these charts. And then finally, I just wanted to close by saying it's really important for the first time that you use these charts to make sure that you have somebody consult with you about how to use it appropriately. It seems, I think, sometimes deceptively simple, and yet there is a little bit more to it than meets the eye. So it's important to try to be sure that you have some expert consultation to help you. And with that, I close my section and give it back to Cindy.
Hello? Hello? It's not on.
I'm still here.
Oh, there you go. Is that Jill?
Yes, this is Jill.
Great. Thanks. Thanks so much. I just want to remind everybody to go ahead and type in, keep those questions coming. We got a lot of questions already, but we're running a little bit behind time. So I'm going to ask us to move on to Steve's presentation. Steve's going to be giving us some examples both in public health as well as in the primary care setting, and we can see how this works on the ground, and then we'll come back and answer all your questions. Thanks very much.
Great, thank you, Cindy. And yeah, we'll be looking at some examples that link the types of processes that can be addressed with statistical process control and this idea of thinking about populations of patients or populations of events in these processes. Next slide. So in the presentation today, we will be looking at a few topics quickly. Let's see, next slide, please. This idea of statistical process control in primary care and how we've come to utilize it based on experiences that have included disease surveillance with the 2002 Salt Lake City Olympics, the point-of-care testing as an influenza surveillance tool, and then finally, as part of our practice redesign, a colon cancer screening example. Next slide. So public health at our institution sits within the School of Medicine, and it becomes a great interface between healthcare delivery and thinking about populations of patients, and this particular approach using statistical process control is well suited to this idea of thinking about communities as patients. We've used that tagline to help a lot of our clinical colleagues understand the role of population health in this environment. Next slide. In the mid-90s, one of my colleagues, Dr. Joseph Lyon, identified as he was working in urgent care clinics that he could typically identify the onset of the influenza epidemic each year because their patient loads increased. He felt like the reports that would often come out of health departments were often more of a post-mortem rather than being timely enough to provide any preventive benefit. So this was something that we decided to take to an SPC type analysis and determine what could be learned about processes that might indicate the onset of this annual event. Next slide. Following some work in that area, we had the Olympics coming to Salt Lake City in 2002. Next slide. In preparation for the Olympics, there were several events that took place in the fall that caused quite a bit of concern over security, and especially as it could relate to events like bioterrorism. There were, of course, the September 11th attacks, followed by the anthrax letters, which took place between September 17th and November 20th, and then the athletes began arriving in Salt Lake City in mid-January, just as the annual influenza epidemic was emerging. Next slide. So it was reported at that time in our local paper that we were starting to use electronic health records and create tools for monitoring abnormal patterns in patient symptoms that could flag a bioterrorism attack. This was basically using an SPC-based approach and constellation of symptoms that were consistent with different types of potential bioterrorist threats. Next slide. During the Olympics, there was this identification through some of our paper pencil surveillance systems that were in place that there was a significant increase in gastro-intestinal distress. We were able to use SPC-based approaches and the University of Utah Community Clinic's EMR system to allow nearly real-time capacity to both detect increases and investigate the shifts, as Jill mentioned, going from common cause to special cause variation. The ability for us to do this allowed us to determine that GI involvement was part of the influenza cases that were occurring as part of the annual epidemic, and so we were able to rule out that this was due to some man-made event. Next slide. We then moved this to refine our approaches to looking at this as SPC-based approaches for surveillance of influenza. Next slide. We were able to evaluate such things as, does influenza-like illness versus rapid testing provide better detection of the onset of the annual epidemic. And you'll see in the top part of this slide, that is the run chart for influenza-like illness, and below it's the run chart for positive rapid tests, and this is for proportion of visits to primary care and urgent care clinics. And the date axis is the same for both of these charts, and you'll see the green actually indicates there is a signal. We've gone outside the control limits, and you see that occurs earlier for use of rapid tests versus influenza-like illness, and this was a common finding we had when we looked at multiple years of data. Next slide. Then looking prospectively, this is an actual run chart from a system we put in place to see if we could detect the onset of the epidemic in advance so that preventive measures could then be implemented. You'll notice there are spikes in this particular chart, and this is because we were using urgent care data, and with weekends, when urgent care becomes a source of care that would typically be picked up by other clinical elements such as primary care clinics, we would see these spikes, and we had to work at identifying a special cause variation that was meaningful versus special cause variation that was simply an artifact of the phenomenon of more patient load because of it being a weekend. Next slide. We then compared the ability to detect the onset of the influenza epidemic with the date that it was identified as occurring after the fact, and found that using this approach and rapid testing, we were able to have both tighter variation, as you can see from this box and whiskers plot, with our University of Utah primary care clinics identified on the bottom of that graphic, versus the system that was in use at that time by CDC, as well as our Utah Department of Health values. Having the epidemic identified a few weeks in advance is particularly useful for preventive efforts, because we can put those in place before the epidemic hits, giving us enough time to recommend precautions against transmission, as well as early treatment if symptoms arise. Next slide. We then took this method to our practice redesign work and looked at colon cancer screening rates. And I'll note, as one of the authors of this particular paper, Brent James with Intermountain Healthcare, who is an adjunct faculty member with us and well known for his use of SPC in refining the clinical processes. Next slide. We had as part of our practice redesign, we've used an expanded medical assistant role, and I'll have more to say about that in a moment. But this particular table shows the script that we put in place for medical assistants, where they would actually be the point of intervention for patients who were due for a colon cancer screen yet had not had one. And you can see there's a question followed by a protocol, whether the patient says yes or no in terms of initiating a process if they have not had one, for attempting to get a referral for them to have a colonoscopy. Next slide. This particular table shows just some of the information from our screening log, both in review of the activities and how they were categorized, as well as how we ordered based on folks who were needing to be screened. Next slide. This is the run chart then that looked at the process, and as Jill had mentioned in her presentation, we ran this long enough that we could establish common cause standards, including the mean and control limits, and then started to institute a series of changes. Initially, there was a change in the EMR alert system that indicated that somebody was in need of at least inquiry regarding colon cancer screening. You'll see that that in fact did not seem to lead to any change in the system, so the common cause variation remained intact. We then instituted in rapid succession provider education and an expanded medical assistant role, and you see a clear change in the system. So special cause variation identified or initiated by these added elements to the intervention. You see that which is common with such interventions, you see that the system then increased the percentage of patients who are getting referrals appropriately, but that started to decline. So in advance of this talk, I did go check on how that system has continued since that point. And while we did see an initial decline as demonstrated in this table, it did level off, and we established a new pattern of common cause variation based on this transition system. Next slide. The conclusions for this particular paper indicated that it was simply not enough to use electronic decision support, but we had to add the additional elements, including provider education and an expanded medical assistant role, in order to initiate the type of change we were hoping to see. Next slide. So in conclusion, statistical process control is an important tool for helping to measure both variation as well as identifying when a system has transitioned. This can be used at the patient, provider, and population levels. We've looked here at population level, whether it be an actual community population and the onset of the influenza epidemic, or a patient population. But this can be done within a provider's panel of patients or within an individual patient if we're monitoring indicators of success with treatment for chronic disease, as an example. Identifying transitions is a start, but understanding the cause and adapting the system to both reduce variation or improve the control and improve performance is key. And as seen in the last example, SPC becomes a very useful tool for at least getting evidence of what are likely initiators of system change. Thank you.
Thanks so much, Steve. And we have about 15 minutes for some questions and answers, and we've gotten a number of questions in so far, so please keep using that chat box and let us know what's on your mind. I'm going to just jump right in here. A couple of people have asked about recommendations for software to perform SPC. Do either of you have any suggestions?
This is Jill. So there are a couple that you may be able to get that would fit nicely into programs you already have. So SAS, for example, has a QI add-on, I believe, and Excel also has some SPC QI data analysis tools. And both of those, might fit into something that you already have.
Steve, anything to add?
Yeah, at the time we were starting this, we used Statit, even though we were using some of these other programs for other analyses that Jill mentioned. But I think it's much more common for a lot of the standard statistical packages to have an SPC component to them. So Stata as well, we've had success with using. So the nice thing is, as it's become more popular in use, it's the accessibility for the software needed to run it is also easier to obtain.
That's great. There are a lot of options out there, obviously. I'm going to kick one over to Jill. There was a question that came in early on before your discussion of limitations and autocorrelation. And the participant asked whether SPC adjusts for autocorrelation, and whether or not control groups are used to ensure that significant changes aren't due to other factors.
Right, so you can definitely set up your SPC analysis with using other groups, for example. So there's a couple ways you could do that. One would be if you have process measures for an intervention group and a control group, you could take essentially the difference in measures for those two and then graph that. And so then you'd be looking at what's the difference between my intervention group and my control group over time. That's what I'm graphing as my intervention effect over time. Another way to do it would be to put both of the groups on the same chart and just look at the two lines to see if they're different. And then you can test that, statistically using regular statistical testing methods on the side or offline, so that it doesn't have to be, it's not necessarily part of the specific chart that you're looking at. And so those are two ways that you could use a control group. And then the other question, Cindy, remind me what the first part
autocorrelation. So what do you do about that? Is there a way to deal with that in SPC?
Right. So SPC itself does not control or adjust for the autocorrelation. What some of the books have suggested is that it probably is not enough to completely ruin the inferences that you get. For example, when they're more concerned about autocorrelation, it tends to be maybe hourly measurements, for example. So those measurements are so frequent and so close together that there's a lot of autocorrelation in that. If you're worried and you're concerned that there might be autocorrelation, one approach is to use every third or fourth measurement, every third measurement perhaps, and then look at the pattern over time in order to try to reduce some of that autocorrelation that occurs from values being too close together.
Great idea. Great ideas. Thanks, Jill. So one of our questioners poses the situation where you've got an outcome measure that there is not very reliable, that there's a lot of variation going on. Are there some ways that you can account for this? Would it be possible, for example, to use multiple measures to increase the power of detecting special cause variation?
Well, let me start, and then I'd be happy to hear what Steve has to say about this, too. There are definitely measures out there where there is a lot of noise and there's a lot of variation. The point of measuring it over a period when you don't think there's anything unusual going on is to establish what is the amount of that natural variation. So if a process is inherently quite noisy, then over 25 measurements, you should be able to figure out what is normal for that particular process. Does that make sense? So it doesn't necessarily matter that it's a fairly noisy thing versus a non-noisy thing. Then if you intervene, you may be intervening to improve the standard of a process, for example. And then you would expect to see the range of noise diminish as well as potentially changing your mean level of a certain variable. So what that would mean is your control limits would get tighter because the variable is not as large within that new process. So what we're saying is it's not all over the map anymore. It's getting to be much more standardized over time. And so you would be able to observe that if it was getting to be a more tightly managed process. You would be able to see that the control limits themselves would, in a later period, you would calculate them over that period to be more narrow. Does that make sense? They would end up being more narrow. So I hope that is helpful. It doesn't mean you can't use it just because you have a noisy
right.
variable.
Right.
Yeah.
I mean, I think that assumes that it's not inherently something that's very variable. But I'm going to see if Steve wants to add to that.
Well, and I'll just add quickly, it's the same as is true with any sort of inferential statistic, and that is we're looking at systematic change in the context of noise variation. And so when there's elements of noise that include an issue with the reliability of the measure, it's going to be a matter of, does the change we're looking for, is it substantial enough that it's going to stand out in the context of that background? And that's why the beauty of SPC is we can start to look at that common variation and understand how stable the process is. If we have a highly unstable process, then we can have changes of a reasonable magnitude that simply won't be detected because the noise is just too great.
Great. Okay. I'm going to switch the topic a little bit, and we had a question about how you would test for significant changes in a process. And the questionnaire suggests maybe a test of two proportions. And Jill, you were breaking up just a little bit on the phone, so if you're doing anything a little differently with your phone, just try and keep real close to it.
Okay, well, I wasn't doing anything different, but I will try to speak directly into the microphone. So the question is how to measure the difference in proportions to see if it's statistically significant. You can use, regular statistical tests to tell if it's statistically different. And then again, what we were showing you here is how to use the SPC criteria to tell whether there's a difference in terms of the nature of the variation.
So, and let me follow up, because I would have been one of those people who had checked off totally unfamiliar at the beginning of the webinar. So I think this may be getting to some questions that I had in terms of the SPC criteria seem to be very dependent on how many, what the interval of the observations were, that you had monthly measurements, but it would be very different if you had weekly measurements to say 6 or more or 8 or more or that kind of thing. And so is there a sort of statistical test that isn't perhaps so dependent that lets you have confidence that, yes, before and after the intervention are different? Because as I understood it, you're not necessarily calculating two proportions when you're doing this.
So the SPC criterion are all based on statistical testing, essentially. And so if you were to find any of the patterns that are described in that set of criteria, then you would be witnessing a statistical phenomenon, meaning that that kind of thing is not going to happen without it being, it's not going to happen randomly. As you recall, when I referred to the Benian et al. Article, that it suggested that those kinds of patterns would occur in the presence of the real change. 99% of the time it's a real change. So what I'm trying to say is that it is all the criteria are based on statistical data from the past that has established these particular criterion as ways to detect true statistical variation. Okay, but the kinds of tests that we are more used to in our data are still available to us. If we want to, for example, if we have a map that of two variables on top of each other and they appear to be correlated, meaning that it looks like the patterns are the same over time, then it makes sense for us to also test that statistically to see whether there is a correlation using a Pearson's R or whatever happens to be appropriate. I hope that helps.
And I'll just add, in terms of the the time frame, that really is dependent on what we're looking at, and so there's a bit of art to deciding what is the appropriate time frame for capture for each of the data points. And then relating SPC to standard statistics, we can almost think of the common process variation as the state if the null hypothesis is true, and whenever we see a signal, that would indicate that we have evidence that the null can be rejected, meaning that the common process variation is no longer intact. So in essence, these decision rules that indicate a signal with SPC are very much in line with the philosophy of standard statistical testing, and we can make the jump to thinking even about the idea of accepting or rejecting the null hypothesis.
Well, thank you both for that answer. And although we have a few more questions, we are just about out of time. So I am going to ask Brianna to close us out with some information about how you can get more information.
This concludes today's Advanced Methods webinar on statistical process control. If you haven't had a chance to register for the other events in our series, please follow the link on your screen. This link will also be sent out to all webinar participants in a follow-up email along with the link to the recording of this presentation. For more information about the AHRQ PCMH research methods briefs on which the presentations in these series are based, please go to www.pcmh.ahrq.gov and visit the Evidence and Evaluation page or follow the link on your screen. Thank you for attending. Have a nice day.
The moderator has ended the conference. Goodbye. Thank you for calling.